Assalamu alaikum, everyone. I'm Dr. Awatif Osama Mohammed, consultant of anesthesia and intensive care, Sudan. We'd like to welcome Dr. Hana Ramila from Indonesia. Hello, Dr. Hana. She had her medical degree in University of Jajah University. Sorry for the pronunciation.
No problem.
And she had anesthesia residency at the University of Indonesia. And also she is doing now cardiothoracic anesthesia fellowship program in Pajajaran University, Bandung. I said it right.
Yes, right.
Yeah. Okay. Welcome, and you can start now.
Okay, thank you, Dr. Awati, for the kind introduction. Assalamualaikum, everyone. My name is Hana. I'm from the Cardiothoracic Anesthesia Division in the Department of Anesthesiology and Intensive Care in Hasan Sadikin General Hospital in Bandung, Indonesia. Greetings to all of you. At this moment, I will share about the anesthesia for thoracic surgery. Okay, we'll just start now, right? Okay. First, for the outlines of the topics that I will discuss in this presentation, first will be about the physiological considerations in a thoracic anesthesia, and then about the one lung ventilations, about the double lumen tubes, then about the perioperative considerations in some thoracic cases and procedures, and the last will be about the lung protective strategy. Okay, first about the physiological considerations in thoracic anesthesia. As we know that the thoracic surgery is quite unique and it has its own challenges for the anesthesiologist. One of the reasons is because that the anesthesia for thoracic surgery, it changes the physiological settings in human being, which is the changes mainly in the breathing system, which is very vital for a human being. These these physiological changes may be due to the lateral decubitus position, the open pneumothorax, and the ventilation and the perfusion mismatch, which occurs in a thoracic surgery. Okay. So as we know, the lateral decubitus position is it can provide the optimal access for most thoracic surgeries. And this position may significantly alter the normal pulmonary ventilation and perfusion relationship, as we say as the ventilation perfusion mismatch. So in the patient, in a awake patient which is positioned in the lateral decubitus position, we know that the distribution of the perfusion or the blood will be more favorable in the lower part. The lower part of the lung in the lateral decubitus position, or the downward part, I will call this as the dependent lung, while the upper lung, I will call this as the non-dependent lung, or the ND lung. Okay. If the patient is still in awake and spontaneous ventilation, the dependent lung will receive also more ventilation, the same as the perfusion. So the perfusion and the ventilation will be more favorable in the lower part of the lung, or the dependent lung. The dependent lung receives more ventilations in the awake, spontaneous ventilating person because of the contraction of the dependent hemidiaphragma is more efficient there. And also the dependent lung is on a more favorable part in the compliance curve, as we can see in the picture. Once the patient is given anesthesia or is under anesthesia, there may occur some changes where the upper lung here, the lower lung or the dependent lung, it will become less compliant, while the upper lung, the non-dependent lung, it will have a more favorable position in the compliance curve here. Okay. Under anesthesia, there will be a decrease in the functional residual capacity of the patient in the lateral decubitus position. So the non-dependent lung will have more ventilation, but it will have less perfusion. But the dependent lung will have less ventilation, but more perfusion. So there is where the mismatch happens. The effect of the anesthesia in the lateral decubitus position, as we know that the non-dependent lung becomes more compliant. When we give neuromuscular blockade agents, the abdominal contents may rise up further against the dependent lung, and it may further press the dependent lung. So the dependent lung will become more restrictive for the movements. Also, if we use a rigid, some bean bag maybe to maintain the position of the patient, it will more give a restriction to the dependent lung. And the opening of the non-dependent side of the chest will further accentuate the difference in compliance, where the upper lung will be more compliant, more or less restricted in the movement. Okay, as we know, the lung is, the surface has a pleura, of course, and the pleura has a negative pressure. This negative pleural pressure keeps the lung expanded. Once the chest is open, the negative pleural pressure will be lost. Then the elastic recoil of the lung on that side will tend to collapse it. Spontaneous ventilation on an open pneumothorax in the lateral position will result in paradoxical respiration and a mediastinal shift, which these two phenomena will cause progressive hypoxemia and hypercapnia. But fortunately, we can overcome this by using positive pressure ventilation. So the mediastinal shift here happens in the inspiration phase, where the pleural pressure is more negative in the dependent lung because this is already open, the upper side, yeah. And it will cause a downward shift of the mediastinum. And this will further decrease, will further press the dependent lung and make it more restricted for the movement. Then it will also decrease the contribution of the dependent lung to the tidal column. While in expiration, it will be the opposite way. Okay, the paradoxical respiration, it happens when there is a to and fro gas flow, because the dependent lung in the inspiration phase, it has a more negative pressure. So the gas that passes through the carina from the upper side of the lung will come to the dependent lung. And in the inspiration, when the risk of pneumothorax is high, the gas flow from the non-dependent lung will pass to the dependent lung. In this slide, I will remind you or refresh about the ventilation and perfusion mismatch. So we can see in this picture, first, this is a normal alveolus with a normal blood vessels. And in the right part here, right upper part, This is we see that the ventilation is smaller, the alveolus is smaller, so it means that the ventilation is decreased, while the blood flow or the perfusion or the Q is still normal. Then this happens, this becomes a shunting part of the lung. While in the right lower part of the picture, we can see that the ventilation is still normal, but there is a constriction or a decrease in the perfusion. This will cause a dead space. And as we know, there is a physiological mechanism in our body, which is called the hypoxic pulmonary vasoconstriction. This physiological mechanism will constrict the blood that flows through the part of the lung with lower ventilation or hypoxic ventilation. So it is called the hypoxic pulmonary vasoconstriction. Okay, next we'll talk about the one lung ventilation. So the intentional collapse of the lung on the operative side will facilitate most of thoracic procedures, but it has the complications in the anesthetic management. The collapsed lung will continue to be perfused while it is no longer ventilated. So this will cause a right to left intrapulmonary shunt, about 20 until 30%. So the mixing of the unoxygenated blood from the non-dependent lung with the oxygenated blood from the dependent lung will make the gradient between the alveolar and the arterial oxygen widen. This may result in hypoxemia. The hypoxemia pulmonary vasoconstriction mechanism that we have, and also surgical compressions or manipulations, it may decrease the blood flow to the non-dependent lung, which will further make the shunting more minimal or minimize the shunting. But this hypoxic pulmonary vasoconstriction mechanism, it is inhibited by some factors, such as very high or very low pulmonary arterial pressures, and hypocapnia, high or very low mixed venous pressure of oxygen, and some vasodilators such as nitroglycerin and so on. It may inhibit the vasoconstriction because, of course, it makes the vasodilatation. And pulmonary infection may also inhibit the HPV mechanism, and inhalational anesthetics. There are also factors that counteract with the hypoxic pulmonary vasoconstriction, such as the high mean airway pressures in the ventilated lung due to a high PEEP, hyperventilation, or high pulmonary inspiratory pressure. And then if there is a low oxygen fraction, it may produce hypoxic pulmonary vasoconstriction, but in the ventilated lung, which we don't want that to happen. Some vasoconstrictors also may have an effect on the normoxic vessels than on the hypoxic ones, which also we don't want that to happen. And the last is the intrinsic PEEP, which may occur if there is an inadequate expiratory time that we set on the ventilator. Okay, for the techniques to do the one lung ventilation, there are 3 techniques. The first, or the more common way, is to place a double lumen tube. The second is we can use a single lumen tracheal tube with a conjunction with a bronchial blocker. And the third is the insertion of a conventional endotracheal tube, but we insert it into one of the mainstem bronchos. The more general way is the first one. So the indications of doing one lung ventilation, it's related to the patient or related to the procedure. You can read by yourself what are the indications. For the procedure related, of course, the main goal is to maximize or give the surgeon optimal visualization about the area that they will do surgery on. And for the patient, it's the main goal is to isolate the healthy lung so that the healthy lung will not get contaminated by blood or by infection from the other lung or the sick lung. Now about the double lumen tubes. Okay, this is a little brief review about the anatomy of the bronchus. As we know that we have two main bronchus, the left one and the right one. The right one, it's more short and it's the position is more vertical, with the length is about 1 until 2.5 centimeters. While the left bronchus, it's more long, about 5 centimeters, and the position is more rather horizontal. So this is the basic anatomy of the bronchus. And this will relate to the types of the double lumen tube that we may use. So some anatomic variations among individuals in the distance between the carina and the right upper lobe orifice will result in difficulty to ventilate the upper lobe on the right lung if we use a right-sided tube. So in general, the left-sided double lumen tube it can be used in most surgical procedures, irrespective of the operative side. So there are some types of double lumen tubes. First, there is the Carlen's type. This is a picture of the Carlen's double lumen tube. It has a carinal hook here, but sometimes the carinal hook is said that it may give us difficulty in when we insert this kind of tube. The Carlen's is a left-sided. Then there is a white double lumen tube. This is like the Carlen's tube. It has a carinal hook, but it's right-sided. And then the Bryce-Smith. It has no hook, but it has a slotted cuff, like this picture. Here is the Bryce-Smith double lumen tube type. And then the most common double lumen tube that we use is the Robert Shaw. So all of these double lumen tubes, it has two luminas or two cuffs. With one will terminate in the trachea and the other in the mainstem bronchus. It has a right side or a left-sided. Both are available. For the size, it is available from 28 French until 41 French. For adult women, we may use from 35 or 37. In general, for the male adult, we can use the 37 or 39. Okay, this is still the different types of the double lumen tube. As we see, the Carlen's, the white and the Robert Shaw type, it has two lumens and it is positioned side by side, but the Bryce-Smith is a little bit different. The two sides are positioned in the anterior and posterior. The Carlen's and the white type here has a hook, but the Bryce-Smith and Robert Shaw doesn't have. Okay, this is still a picture of the double lumen tube. Okay, as I said earlier, that in general we can use the left-sided double lumen tube, regarding which side of the lungs that will be operated or will have surgery. But there is an indication when we have to use the right double lumen tube. First is when there is a distorted anatomy of the left main bronchus, maybe by intrabronchial or extrabronchial mass, which will make us more difficult when we use left-sided double lumen tube. And then if there is a compression of the left main bronchus, then also if the procedure is on the left side and the procedure is such as a pneumonectomy or single lung transplant or a sleeve resection, of course, we cannot use the left double lumen tube because it may interfere the surgeon in doing the surgery. But as a note here that studies have failed to detect the differences in clinical performance of using the right and the left double-sided lumen in clinical use. Okay, for the placement of the double lumen tube, here is a picture of the double lumen tube that we usually use. Here is the bronchial cuff and there is a tracheal cuff. There's a blue part and there's the white part. The way I remember it is that the blue is the bronchial, so blue bronchial, that's how to remember. Okay, first, after we insert the double lumen tube, we have to inflate the cuff, right? The bronchial cuff is smaller, so it may be inflated just by 1 or 2 or maybe 3 milliliters of air. But the tracheal cuff, it's more bigger. It may inflate with 5 until 10 milliliters of air. Okay, after inflating the cuff, we have to check for the bilateral breath sounds in both parts of the lung. Then after that, we try to clamp one part and then we check whether the placement is already as we want it to be. Okay, next about the perioperative considerations in some thoracic cases and procedures. Well, actually, there's a lot thoracic cases and procedures that are available, but this is, I just put in some of the most common procedures that we usually do. First, it's about the lung resection. The important part also is the preoperative pulmonary assessment before we do the surgery or before we do an anesthesia for a patient which will undergo a lung resection. So in the preoperative, of course, we have to do history taking, physical examination, check the labs. We also have to evaluate the radiography pictures. If there is a CT scan or MRI, we should also know that. And then the more specialized evaluation for the patient which will undergo a lung resection is, of course, the pulmonary function. Here is a 3-leg stool pre-thoracotomy respiratory assessment. It has 3 components. The first is where we evaluate the respiratory mechanics by calculating the predictive post-operative forced expiratory ventilation in 1 second. We can do this by using the spirometry or pulmonary function test. And then we also have to evaluate the cardiopulmonary reserve for the patient. We can use like a cardiography or something, but we can also assess it by looking at the physical activity that is capable to be done by the patient, such as stair climbing, or which the patient can do exercise. And then we have to also evaluate the function of the parenchyma of the lung. Okay, this is an algorithm for thoracotomy and major anatomic resection. This algorithm is provided by the American College of Chest Physicians. First, if we can divide the patient by two categories. Maybe if the patient is like in the fit condition, still young, maybe they don't have to undergo the cardiopulmonary exercise test, because we can think that they're still in normal cardiopulmonary reserve function. So we should do just the pulmonary function test, and we can also have a blood gas analysis. From this algorithm, we will know whether the patient is at low risk, moderate risk, or high risk in undergoing a thoracotomy or major anatomic resection. Okay, this is a little bit of the way how you can use the or how you can count the post-operative forced expiratory ventilation in 1 second. We calculate it by knowing the preoperative FEV1, and then we times it by 1 minus the percentage of the functional lung tissue that is removed, and then divided by 100. So we have to also communicate with the surgeon, like to know how much part of the lung will be removed. And then some histories in the patient, such as smoking. We know it is a risk factor of COPD and also coronary arterial disease. So if the patient has a history of smoking, we have to remember that it may have effects on the lung of the patient and also in the cardiac reserve of the patient. We can use an echocardiography to know the baseline cardiac function of the patient. And in the patient with lung tumors, we have to remember that there is also complication that may occur related to the local extension of the tumor and the paraneoplastic syndrome that may be that the patient may have. And then if there are CT scans or MRIs, we must refuse that also. So in the preoperative assessment, we also have to assess whether there is a tracheal or bronchial deviation, and then is there any compression of the mass to the airways, any pulmonary consolidation, atelectasis before the surgery, and whether there's effusion, pleural effusion that will predispose the patient to hypoxemia. And if the patient has a cyst, cyst or abscess, we also have to know that. And then for the intraoperative management, of course, the preparation phase is very important. We prepare the patient from by doing from the history taking, all the physical examinations and the lab examinations. And then we also have to prepare the operating room, all the drugs or the airway management devices that we will use. And then the patient must have large venous access, of course. We have to have a blood warmer because mostly we will do some transfusion intraoperatively. And then we also have to prepare searing pumps and rapid infusion devices. The arterial line is indicated for a resection of large tumors. And it is also recommended to give a central venous catheter on the patient. And we also have to manage the position of the patient. For the patient with a pulmonary cyst or bulla, we know that the large bulla can impair ventilation by compressing the surrounding lung. And this bulla may have such as a one-way valve where air can go inside the bulla, but it cannot go outside. So it has the tendency to enlarge. And the greatest risk of the anesthesia in patients with pulmonary cyst and bulla is that the rupture of the air cavity while we are giving positive pulmonary ventilation. And this may lead to a tension pneumothorax. So the induction of anesthesia is recommended with maintaining the spontaneous ventilation until the site of the defect is isolated with a doubloon tube. And assisted ventilation is necessary to avoid excessive hypercarbia. And remember that the use of nitrous oxide is contraindicated in this kind of patient. When a rupture of a bulla or cyst occurs, the signs and symptoms may manifest such as hypotension, bronchospasm, and abrupt rise in peak inflation pressure. So we may have to insert a chest tube. Next, in the patient with a lung abscess, the lungs, of course, must be isolated to prevent contamination to the other lung, which is still healthy. And for induction, it is recommended to do a rapid sequence. And using a double lumen tube is highly recommended. And while doing the induction, it is recommended also to position the diseased lung in the dependent position or in the lower position. But once the DLT is placed and the both cuffs of the double lumen tube is inflated, then we can position the patient with the part where there is the lung abscess in the non-dependent position. And we must do a frequently suction to make sure that the healthy lung is not contaminated with the abscess. And then FATS. This is a minimally invasive procedure where the surgeon usually gives like 2 or 3 small incisions in the thoracic wall. The indication of this procedure is for lung biopsy, segmental or lobar resections, pleurodosis, and so on. And for this procedure, double lumen tube is required because the surgeon must have a good visualization of the part of the lung which is undergoing surgery. The next is about bronchoscopy. Bronchoscopy is done mostly for diagnostic purpose. It is usually a short duration procedure. We can use an endotracheal tube or laryngeal mask airway to facilitate this procedure. Okay, the next is the lung protective strategy. So the lung protective strategy, or the strategy where we give mechanical ventilation for a patient undergoing thoracic surgery, it's quite tricky. When the surgeon wants or gives the instruction for us to do one lung ventilation, we must use lower tidal volumes, and it is recommended to use give positive and expiratory pressure about 5 until 10 centimeters of water, and it is also recommended to give lower oxygen fraction around 50 until 80%, and we must maintain the ventilatory pressure or the filtration pressure less than 25 centimeters of water. And for the peak airway pressure, we must maintain it lower than 35 centimeters of water. by the use of pressure controlled ventilation, which is more recommended, and permissive hypercapnia. But monitoring of the patient and the mechanical ventilation on the time where we give the one lung ventilation is extremely important. So what happens if the patient becomes hypoxic? First, do not panic. We should confirm the position of the doubloon tube, confirm the position of the bronchial tube. Try to do some suctioning. Try to increase the oxygen fraction until 100%. And then we may do a recruitment maneuvers on the dependent lung to eliminate atelectasis and improve shunting. And try to optimize giving the positive and expiratory pressure to the dependent lung. And we also must make sure that the patient is in adequate cardiac output and oxygen carrying capacity by monitoring the blood pressure, also how much blood has the patient bleed inside the procedure on the operation. And then we can also use a continuous positive air pressure or blow by oxygen to the non-dependent lung. But we also have to communicate with the surgeon, of course. It may decrease shunting and also improve oxygenation, but do it cautiously. And if there is severe hypoxemia, communicate with the surgeon, and we may have to do the two-lung ventilation again. If it is possible, we may ask the surgeon to do a pulmonary arterial clamp, which can also eliminate shunting. And in patients with chronic obstructive lung disease, we may have to think or suspect that there may be a pneumothorax in the dependent lung, which we'll have to manage that first. Okay, I think that is the end of my presentation. Thank you. I'll give it back to Dr. Awatif as the moderator.
Thank you, Dr. Hana. Thank you.
Yes.
That was a very nice and informative presentation. And thank you for participating with us. I would like to give the mic to Dr. Amna Mustafa. She's a consultant of anesthesia and intensive care, and she is a senior cardiothoracic anesthesiologist in Sudan. Now she's working in Ahmed Qasim Hospital.
Okay, thank you, Dr. Awatif. We are so glad to have this very rich talk from Dr. Hana. We would like to thank her very, very much for the very nice piece of information that we have gathered in this lecture. It's very informative. Dr. Hana, I have got a few comments.
Yes.
Regarding the placement of the double lumen tube, we don't have here always in all facilities, we don't have the fiber optic scope. We rely on our clinical experience, so that before setting the patient into the position, we make sure that we are ventilating which lung, and after positioning, we check back, but no other way of doing things. Really, it is tough. Even if we want, we need to have this experience of what do you see when you put the fiber optic scope in, and we need some comments on that, please.
Okay, thank you, Dr. Amna. Assalamualaikum. Okay, for in my place also, we don't routinely use the
Dr.
I'm sorry,
Hana,
still.
you closed
Yes, I'm sorry. I'm sorry, I'm still muted. Okay, Dr. Amna, in my center, we also don't regularly use the bronchoscopy to make sure about the position of the double lumen tube. But in some procedures, the where the big surgery, large surgery, such as a pulmonary resection, of course, we have to make sure about that. Actually, what we see when we put the bronchoscopy inside the double lumen tube, of course, first we put it in the tracheal part, and then we are supposed to it is supposed to we can look at the carina. The carina, if we put the double lumen tube inside the tracheal part, and then we can also make sure with using the bronchoscopy, we can also make sure that the end of the bronchial part of the double lumen tube, it inserts or it goes to the right part of the lung, which we want. An example, if we use the left-sided double lumen tube, then when we look by the bronchoscopy, we can see that the tip of the bronchial part of the double lumen tube, it goes to the left part of the lung of the bronchos. I think it's mainly like that, Dr. Amna.
Well, you go through the tracheal tube, and you see the cuff. You can see the cuff of the bronchial. It's a semilunar or crescent shape, something like this. That means it is the cuff is halfway. It is not. If you see the whole cuff, that means you are outside. You are not inside the bronchus. And if you don't see the cuff, that means you are far inside. That's what we are taught, but I don't know exactly how it looks like. You always go through the tracheal, not the bronchial, because it is small, I think, isn't it?
Yes, right. The tracheal is bigger and the bronchial is smaller. Sometimes we need a smaller size of bronchoscopy if we want to put in the bronchoscopy to the bronchial side. So we usually put it in the tracheal. Okay. And we make sure from that.
Thanks very much, Dr. Hana. Thanks very much.
You're welcome, Dr. Amna.
Thanks a lot.
Thank you, Dr. Amna, for your participation and comments. Can we ask Dr. Elena to give us her comment, please? Dr. Elena is a cardiac anesthesiologist from As-Salam Hospital, and I don't know if she's listening now. Dr. Elena?
Yes, we are here with some residents of the group that there is. We have Dr. Sara, Dr. Mawada, Dr. Shima. We are from Salam Center.
Okay. Welcome. And do you have anything to add to us?
It was very nice presentation. I don't have experience in thoracic, so it was really very well done. Unfortunately, I cannot comment because I don't have experience in this kind of specific surgery.
Okay, thank you, Dr. Elena. Thank you, Dr. Hana. And we had a very great lesson today about how to deal with lungs and how to deal with single lung ventilation and how to do protective lung strategy. And it should be done for one lung or two lungs. Dr. Amna, do you have another question?
Yes, please. If nobody else has got a question.
You can talk.
Okay, Dr. Hana, I would like to ask you about bronchial blockers. I just saw them, and I never used them. How do you find them useful in practice, especially for pediatric cases? Maybe we don't have the lumen tubes less than 28 millimeters. maybe they are useful for pediatrics. Can you tell us about your experience with bronchial blockers, please, Hana?
Okay. Okay, thank you, Dr. Amna. Very nice question. The use of bronchial blockers. Actually, in my education until now, actually, I also never used the bronchial blockers. So I just read about the bronchial blockers in the textbook or by doing some internet browsing like that. In the use of the bronchial blocker, actually, I also haven't have no experience with it. I asked some colleagues which have the experience for using a bronchial blocker. Actually, it's not a real bronchial blocker. My colleague once used Fogarty catheter. You know, Dr. Amna, the catheter for embolectomy. Maybe vascular
Yes,
surgeons do
yes, I saw it. I know
use
it.
that. Yes. I was informed that that could be used for a bronchial blocker, but in my education here in Indonesia, actually, I also haven't have experience in using a bronchial blocker. While for pediatric patients which will undergo thoracotomy, it's always a challenge for us. There's no double lumen tube, but I think the most important thing or aspect in doing thoracotomy procedures with in pediatric patients is communicating with the operator. They know that we don't have double lumen tube, so we can't completely isolate the healthy lung from such as blood or what abscess or something from the sick lung. But we try to communicate with the operator so they do the surgery very cautiously, very careful, so they won't make any spills to the healthy lung. I think that's one important factor. And maybe if for the pediatric patient, I never have experience in using the bronchial blocker, but sometimes I just insert the single lumen endotracheal tube to the healthy part of the lung to make sure that the healthy lung is still isolated. Like that, Dr. Amna.
Yeah, that's great. That's great, Dr. Hana. Yes,
Yes.
usually we do like this. We have no other way. Thanks
Yes.
very much.
Yes,
Thanks.
you're welcome, Dr. Amna.
Yeah.
Thank you, Dr. Hana. Thank you, Dr. Amna. Dr. Amna is our mentor and our senior consultant, and she always teaches a lot in cardiothoracic anesthesia. And thank you, Dr. Hana, for this presentation. And you were very keen to help and to teach and to give information. That's very nice. And we hope that we can present a fruitful presentation for you at University of Indonesia, inshallah.
Inshallah, yes. Yes,
Okay.
Dr. Awatif, this is also a new experience for me, giving a sharing with colleagues in overseas. I think maybe if it was not because of COVID, maybe this won't happen. I think we will not be used to using Zoom like this. So I think we can break the boundaries of time and space by using this kind of methods for giving lectures or sharing knowledge, right?
You're right. You're right. Actually, COVID have made people much more closer to each
Yes.
other than before. Yes, and teaching and education is now at the reach of the hand and just at the bottom of the laptop. It's nothing. And
Right.
I hope, inshallah, we will help you too in education, and we will present something, inshallah, for you and for your colleagues, inshallah. And I hope you, inshallah, succeed in your fellowship. And
Yes.
thank you very much. Thank you all for this presentation, and thank you for attending and listening. And see you next Saturday at 12 p.m. Thank you. Bye.
Thank you.